Welcome to Roadmap to Residency Evidence-Based Applications. Hello everyone, I am Abhiraz. Welcome to our Club 250 Maker sessions. We are currently in our renal pharmacology modules, and in this video we will be talking about renal drug adjustments. So first of all, we need to know about the CKD and the renal failure according to the GFR. So whenever your GFR is at 60 or greater, okay, is at the lower baseline, then you are at increased risk of having a CKD. Kidney damage with normal or increased GFR is thought to be a 90 or greater. Kidney damage with mildly decreased GFR is 60 to 89. Moderately decreased GFR is 30 to 59, and severely decreased GFR is 15 to 29. Now, whenever the GFR comes down below the 15 number, then you are required to undergo dialysis, and this is called as the end-stage renal disease. So why you need dose adjustments? So majority of the drugs are eliminated by the kidney. So it is mandatory to make appropriate doses modification when renal function deteriorates to prevent the drug toxicity. So, for example, if there is drug input, then some of the drug will be excreted in the kidney, and some will again go into the circulation back. But if the GFR is less than 15 or the GFR is severely decreased, then the most of the drugs will not be excreted, and there will be drug toxicity because more of the drugs will be remaining in the system. You need the drugs to get metabolized and go out of your body to get excreted from your body. But if that is not occurring, then there will be drug toxicity or overdose. So stepwise approach to adjust drug doses regimens for patients with CKD and AKI is that first you need to obtain the history and relevant demographic and clinical information. You need to assess the demographic information, past medical history, including history of renal disease and current clinical and lab information to assess the current clinical needs of the patient. Estimate the GFR. So use most appropriate tools to assess the eGFR or uh, creatinine clearance of the patient based on the age, body size, ethnicity, and concomitant disease states. Review of current medications. So identify drugs for which individualization of the treatment regimen will be necessary. Calculate individualized treatment regimen. So determine treatment goals, calculate doses, regimen based on pharmacokinetic characteristic of the drug and the patient's volume status and eGFR or creatinine clearance. Monitor parameters of drug response and toxicity. Monitor drug levels if available or applicable. Devise regimen. So adjust regimen based on drug response or change in patient status, including renal function as warranted. So pharmacokinetic consideration. So uremic patients may exhibit changes in bioavailability, prevalence, and volume of distribution. The oral bioavailability of a drug in severe uremia may be decreased as a result of disease-related changes like uh, gastrointestinal motility, PS that are caused by nausea, vomiting, and diarrhea. Mesenteric blood flow may also be altered. The apparent volume of distribution depends largely on the drug protein binding in plasma or tissues and total body water. The renal impairment may alter the distribution of the drug as a result of changes in the fluid balance, drug protein binding, or other factors that may cause changes in the apparent volume of distribution. So they are the example of the drug that are eliminated exclusively by the kidney, like benzyl penicillin, ampicillin, acyclovir, gentamicin, sotalol, atenolol, or tetracycline. And these are some drugs that are almost entirely metabolized by the kidney, like clindamycin, propranolol, rifampicin, lorazepam, doxycycline, nortriptyline, or warfarin. Now, drugs that do not require dosage adjustment will be moxifloxacin, azithromycin, ceftriaxone, clindamycin, linezolid, tizicycline, ambizome, voriconazole, or gravulate. So how to adjust the dosing regimen? So you need to first reduce the dose of the drug and dosing interval may be constant, or you can just make the dose of the drug constant, or you can decrease the dosing interval, or you can increase the dosing interval. So there can be two ways. So first we can change the dose, another is you can change the dosing interval. So basis of the renal dose adjustment based on the elimination of the drug is that upon the loading dose and the maintenance dose. So the loading dose depends upon the volume of distribution. So the volume of distribution is not altered in the renal failure patients. So loading dose usually do not need to be adjusted in patients with chronic kidney disease, whereas the maintenance dose depends upon the clearance of the drugs, and due to the decreased excretion, the decreased uh, clearance of the drugs is there. So the drug dose adjustment or the maintenance dose should be required. So as the volume of distribution of drugs, especially hydrophilic antibiotics, including beta-lactams, cephalosporin, penems, are significantly increased in the presence of AKI, the administration of aggressive loading doses are highly recommended. So, for example, we have a patient who is a 38-year-old woman who was admitted to the PICU after a gunshot wound. Now, she is 5 feet 6 inch and weighs 65 kg. She is on the following medications: piperacillin 4 gram IV every 6 hours and IV ciprofloxacin 500 mg PO every 12 hours. She has suddenly gone into renal failure and has a serum creatinine of 3 mg per deciliter. So, what dosing regimen changes would you like to do in this patient? So FE of piperacillin is 0.8 and FE for ciprofloxacin is 0.5. Now this value will be given in your question. So then we have the age of the patient is 38 years. The weight is 65 kg. Height is 5 feet 6 inches. Piperacillin dose is 4 gram every 6 hours, and ciprofloxacin dose is 500 mg every 12 hours. So whenever you use the Cockcroft-Brod formula, that is 140 minus age into weight by serum creatinine into 72. Okay, so then we have to use there is something called as the estimated body weight of the patient. So the actual body weight is used in the underweight patients, so where the body weight is less than the estimated body weight, and the ideal or body weight in patients of normal weight if the body weight is less than 1.3 of the ideal body weight. So adjusted body weight is used for overweight, obese, and morbidly obese patient. Okay, so adjusted body weight would be IBW plus 0.4 into BW minus IBW. Okay, now this is something that you need to adjust the body weight. Okay, because there are fat somewhere, there are increase in the lean body weight in some patients, right? So after you find out the creatinine clearance, then you find out the renal function. Okay. Now, for the dose adjustment of piperacillin, you need to find out the Q. Okay. So normal dose into Q. So Q equals to 1 minus Fe, that was given in the question, 1 minus renal function. Okay. So it comes to 0.35. So normal dose would be 4,000. So gram into milligram. So 4,000 into 0.35. Then that will give you the adjusted dose. So adjusted interval will be normal interval by Q, and that will give you the adjusted interval of the dose. Similarly, for ciprofloxacin, it is same 500 into 0.595, and the adjusted interval will be of 20 hours. Thank you for watching. Keep studying hard.